Good afternoon. My name is Nikolaos Diakos. I'm a cardiologist at the Texas Heart Institute, and I'm very happy to be joined at the studio today by Dr. David Brown. Dr. David Brown is a professor of cardiology at the Keck Medical School at the University of Southern California, and we were very happy today to have him at the Texas Heart Institute, and he gave grand rounds about the management and the diagnostic approach for stable coronary artery disease. Thank you, Dr. Brown, for joining us today.
It was a great honor to be here. I'm thrilled to be back in Houston after many years away.
It was great, and I really enjoyed your talk. Before going to ask you a couple of questions specifically about your talk, what I noticed is that you are a public speaker, and one of your mottos, actually, and I guess that's the motto that you follow when you practice medicine, is less is more cardiology. Tell me, how easy is it to practice that in a society that expects you more, or they think that the more you do, the better? Do you educate your patients? Do you educate your referring physicians that when they send you a patient, they expect you to do things that sometimes they're not need to be done?
Yes, that's an ongoing struggle because in our society, patients equate testing with caring. And the more tests you do, the more caring they think their doctor is. So it requires a lot of education of them. I frequently have conversations about testing, what it means if it's abnormal, the good, the bad, the downstream testing, the complications of downstream testing, the impact on outcomes, which in many cases, as I spoke about today, we don't have any favorable data that outcomes are improved. But it takes a lot of time, a lot of education. I think a lot of my fellow cardiologists just kind of roll their eyes when a fellow will say, well, Dr. Brown said that we could just treat this patient medically. And referring doctors, I have to be very explicit in my notes. I frequently put citations for, the few key studies like ischemia, courage, orbita, so that they can look it up if they want. But yeah, it's an ongoing struggle, but, it makes life interesting.
Yeah.
I started out in interventional cardiology sort of in the time before READIT 2 was published, and we just assumed that we were saving lives by first balloon angioplasty and then stenting stable coronary disease. It was just an assumption. And when I think of how many cases I did and some of the complications I had in pursuing that route, it gives me a cold sweat. But I mean, I did, when Courage came out, it was a time for sort of major personal and professional reevaluation of what's going on here? Why are we doing this? We need more data, et cetera.
With your talk today, you pretty much presented all these big trials that challenge what we thought as interventional cardiologists. A significant lesion in one of our arteries, a significant narrowing in one of our arteries needs to be revascularized.
Yes.
And you beautifully showed that it's not the case necessarily. And to me, as an interventional cardiologist also, the struggle is that when you get this referral for a patient with a positive stress test, which is totally asymptomatic, and the question that almost like 70, 80% of the patients have is, are you going to put a stent on me? Because I think if you don't, I'm
Yes.
going to die.
Yes.
And I'm going to have a heart attack.
Yes.
So how do you answer that question to a patient that comes and says, doctor, you need to put a stent on me because I think I'm going to die if you don't put a stent on me. And the patient is totally asymptomatic.
Yeah. I mean, I go back to the beginning and I talk about the paradigm that it's not like the rusty pipe in your bathroom that gets progressively clogged over time and ultimately it'll be completely clogged. That most of the lesions that kill people are actually not the 90%, but the 20 and 30 that you can't, if we stented all of those, you would have complete metal arteries. And, I reassure them that I go into the biology a little bit of plaque rupture, and I tell them that the thing that prevents plaque rupture is getting your LDL as low as possible and having a healthy lifestyle, eating well. And a lot of times they don't want to hear that. And, I've had not very many, I'd say I can count on one hand, where we just agreed to disagree, and I suggested they find a different cardiologist. But most people, if you take the time, will be persuaded by the data and the fact that you are caring, and the fact that you're not doing more tests and procedures doesn't mean you're less caring and that you're available. I mean, when I start a new patient on anti-anginal therapy without doing all the testing, I give them my cell phone number. I see them back very quickly in 2 or 3 or 4 weeks, depending on what my schedule and their schedule is. I see them a lot. And after you've seen somebody for 2 or 3 times in a row, every month or every 6 weeks, and they're feeling well, and you develop a rapport with them, then it becomes much easier for them to accept that the treatment is effective.
And it's, as you said, it's important patient communication. It's important the patient to even be notified that, that I'm starting your medical treatment as these studies of thousands of people recommend.
Yeah.
But, there is a chance that the medical treatment is not going to be effective. So we're going to be in touch. We're not like, pat them on the back and they will say, bye, I'll see you in 6 months.
I explained to them that you may need a stent at some point when you become symptomatic, because it's not perfect, but it's better than medical therapy for relieving symptoms. So if you ever get to the point where your quality of life is impacted by the symptoms you're having, it's not a blanket refusal to refer people to the cath lab. It's just selective referral.
My favorite part of your talk, and you touched with your answer, is this slide that you saw on the left panel, that you saw that ischemia symptoms did not correlate with the outcomes.
Right.
While disease burdens is correlating with the outcomes.
Exactly.
And my understanding is that what we see when we do an angiogram and we see these lesions and these narrowings in our epicardial arteries, the big arteries, it's pretty much the tip of the iceberg. And the microcirculation also has disease. And the way to address the microcirculation is by medical therapy, as you said.
And lifestyle.
And lifestyle changes. Yeah. How do you approach, do you do first lifestyle changes? Do you give them 2 or 3 antiangials? How is your stepwise approach for our primary care physicians that listen to us?
Yeah, if they come on no medicines, but with an anginal sounding syndrome, I'll choose medicines based on their background medical issues. Are they hypertensive? Do they have asthma and can't take a beta blocker? Do they have migraines, in which case you want to stay away from nitrates? But I will, sometimes when I'm not sure, and a lot of patients, it's not a classic history. Some of those patients I'll just give, a bottle of sublingual nitro, say, keep a diary, mark it on a calendar, every time you take one, and score 1 to 5 based on the degree of angina relief, with 5 being total angina relief within 5 minutes, and then 4, 3, 2, 1. And bring your calendar with you when you come back to the office. And, you'll see no relief from sublingual nitro, even if it's repeated 2 or 3 times. Well, that's unlikely to be ischemic disease. If they do have relief from it, I usually start with Imdur, assuming they don't need to be on a beta blocker for another reason or something. But then we'll go to a beta blocker, then we'll go occasionally to ranolazine. Very few patients I've used ivabradine on. It's hard to get it approved. It's very expensive.
Yeah, it's very expensive, yes.
And I tell them, especially the ones that have either had a coronary angiogram or a CTA where they don't have obstructive disease, I tell them, and they may have had a PET that shows a reduced CFR. I tell them that we know what you have. We can make you feel better. But unlike much in cardiology, it's trial and error. So we're going to do different combinations of drugs at different doses, and it's going to take a while. And I'm going to be here with you, and I'm going to talk to you on the phone, and we're going to find a combination that works. And I think that's why, both groups in Courage had less angina over time, because their doctors were, they weren't getting more and more stents. Their doctors were playing around with the medical therapy, and I think microvascular disease is reversible over time if you get their LDL down and they modify their lifestyle. But it takes 2 or 3 years, as we saw in Courage.
And do you think, since now we know that the microvascular disease or the disease burden, as you said, correlates with outcome, do you think we should somehow incorporate it in our future trial designs versus chasing positive stress tests?
Yeah. I mean, there have been a couple of small trials of treatment for INOCA, and shows improvements in quality of life, but not so much quantity of life. But to me, the big thing is this iceberg of microvascular disease in the people with epicardial disease that we completely don't talk about.
Yes.
I mean, in my ideal world, somebody would show up in the cath lab to get an epicardial disease stented. The stent would be placed, the lesion would be fixed, Before they left the lab, they would have their CFR measured and maybe have acetylcholine provocation. If both those things come back normal, my prediction is that patient is going to have a very successful result.
Yes.
If those two are abnormal, they're going to maybe feel somewhat better, but they're not going to have complete angina relief. And you know that, and they know that when they leave the cath lab, rather than thinking, oh, there's something wrong with me. I just had a stent placed and I'm still having chest pain. And a lot of those patients are afraid to tell the interventionalist because they don't want to disappoint them because they know, they put a lot of effort and skill into treating the lesion.
And that's why probably the studies that the Orbita that had the sham arm that they said, okay, people didn't know if they got a stent or no. Then people did not have equally symptoms because of that. The last thing I would like to ask you, and that goes with the financial. Okay, so you showed that in testing people with stable coronary disease, we spend probably $21 billion, something like that, right? And people have to realize that we do not affect the outcome and we still spend this money. And that's important nowadays. One scenario that I commonly get is a patient that got a calcium score, totally asymptomatic patient, got a calcium score for risk, modification and intensification of his statin treatment, okay? That comes positive in the moderate rates, potentially. The next thing you know, he got a stress test. The next thing you know, he is in your office with his family, very anxious whether I'm going to get a stent and asking, can I get an angiogram to make sure that everything is okay? And the amount of money that is spent is a lot. So the cardiologists that are ordering those calcium scores nowadays, that's something that we have to take into account and how to follow them. And I don't know what's your experience in that.
I mean, I just wrote an editorial that was published 2 weeks ago in JAMA Internal Medicine about my disdain for calcium scores, mostly because, one, there's no outcome data, but two, it leads to all kinds of inappropriate downstream testing because 99% of the people that get calcium scores are asymptomatic. The only thing we can do with invasive cardiology outside of an acute coronary syndrome is make symptoms better. And if they're asymptomatic, why are we going down that rabbit hole of testing and expense and radiation and potential complications?
And for sure, I just would like to point out, and you said that multiple times, that does not apply in the 100% of the patients. There are patients that they have extremely proximal disease, what we call left main disease, or there are patients that they have very low contractility of their heart, and those patients they have shown that they get better with a bypass surgery or with revascularization, whatever that is, either a stent or a bypass surgery. So just to kind of educate the community, and also just to clarify, you're talking about this stable coronary disease.
Stable only,
Stents still save lives. People that they come with an acute heart attack in the hospital, this is a treatment that
every day lives are saved.
Are saved by stents in this population. I would like to thank you one more time.
It was a great honor.
That you're here with us today and giving us such a great grand rounds for us.
It was my pleasure and a great honor. Thanks.
Thank you very much.